Bismillahirrahmanirrahim. Today we will talk in our third part of MR Defecography, part 3 teaching session of ERA. As we discussed before that our image or our technique for MR Defecography is divided between static image and dynamic image. And let us start by the static axial T2 image. This is the first plane that we need to see. We will scroll the image in the axial plane. We need to search for any intra-abdominal pathology or something make increasing pressure inside the abdomen or the pelvic cavity that may explain pelvic organ descent. We will go in the axial plane. One of the most important part to see or comment the puborectalis muscle. This muscle should preserve its normal thickness, as you see here, and should be symmetrical, with no thinning out or defects or any abnormality in its morphology. We should also see the vagina. The vagina should preserve its H shape or butterfly configuration, as you see here. This is the urethra anteriorly, and this is the vagina posteriorly. This is the vagina posteriorly, and this is the urethra anteriorly. So the vagina symmetrical in its morphology, preserving its configuration, H shape or butterfly. So we don't have any paravaginal defects or any abnormalities that may lead to significant pelvic organ prolapse. I think this is the most important point. Also, if we need to measure the width of the levator hiatus or the anteroposterior diameter of the levator hiatus, you can measure it in the axial plane. Let us go to our coronal plane. Our coronal plane, the most important point that we need to comment the levator ani muscle. There is mild thinning out of the levator ani muscle, but still preserving its upward convexity and symmetrical. We don't have any significant abnormality in the uterus or ovaries or sigmoid or rectal colonic segments. We will go to the sagittal plane. The sagittal plane is very important. Here, the uterus is retroverted, slightly retroverted. The bladder is in place. The urethra is vertical. The rectum is markedly distended by gel as we prepared the patient. We don't have any descent in the resting state. Let us apply our lines and angles. We will start by the BCL, pubicoccygeal line. This line is connecting the inferior surface of the symphysis pubis into the last coccygeal segment or last coccygeal joint. So this is the PCL, and we can draw the H line. H line, this one, connecting the puborectalis muscle. This is the puborectalis muscle, as you see here. This is the point or the angle of this anorectal triangle. We can start from here down to the inferior aspect of symphysis pubis. This is called H line. This one measures 4.2 centimeter. The normal dimension in the resting state is below 5 centimeter, so it is accepted. We also can draw from this point also a line perpendicular to the BCL. This is called M line. This is line that is confined or very specific to how much degree is the pelvic descent. This one measures about 1 centimeter, so it's accepted in the resting state. So we don't have any significant descent or widening of the levator hiatus dimension because H line indicates or reflect the anteroposterior dimension of the levator hiatus. So we don't have any significant abnormality. Let us measure the anorectal angle. As we discussed before, the anorectal angle is the line between the anal canal and the posterior rectal wall. This one measures here 120 degree, so it is accepted. And as you see here, all the organs are still preserving its normal relationship to the pubococcygeal line. Let us shift to our dynamic study or functional images. So in the dynamic image, we will ask the patient to strain, and this is a single shot T2 weighted image during straining. Let us see what happened in the straining. First, you will see significant descent for the anorectal junction during straining, and there is anterior rectal bulge. Let us measure the angle, anorectal angle, the line parallel to the anal canal and the line parallel to the posterior rectal wall. This angle was increased to be 140. So as we compare to the resting anorectal angle between 120 to be 140, about the difference is around 20 degree, so it's accepted. We don't have any spastic or paradoxical muscle contractions for the puborectalis muscle. The angle is accepted to be increased between the resting and the straining. But we have here significant descent for the anorectal junction. Let us see the remaining image during straining. We ask the patient to strain and to reach the maximum point of straining. Here is the maximum point of straining. We found that this is a PCL, pubococcygeal line, and this is a bladder neck. Look for this one. This is the bladder neck. The bladder neck, it descends down or inferior to the PCL by 1.4 centimeter. 1.4 centimeter, we are applying rule of 3 for all pelvic organs except the M line and the rectocele, as we discussed in the previous lectures before. The bladder neck here measures about 1.4 centimeter. So if we are applying rule of 3, between 0 to 3 centimeter, it is mild degree. From 3 to 6 centimeter, it is moderate degree. More than 6 centimeter, it is severe degree. So we have here mild degree of cystocele. Also, we have here the orientation of the urethra, most likely horizontal. So we have urethral hypermobility. And sometimes the urethral orientation, if it is kinked or transverse orientation, this can make difficulty in urination. Also, we have here the uterine cervix is below the PCL. It measures about 1.7 centimeter. So if we are applying rule of 3 as well, so it is mild degree of descent for the middle compartment. We don't have any peritoneal defect. We don't have any invagination for the bowel loops between the rectum and vagina. So we don't have any peritoneocele, or we don't have any enterocele or sigmoidocele. Just we have mild degree of prolapse of anterior compartment and mild degree of prolapse of the middle compartment. Regarding the posterior compartment, the M line measures 5.3 centimeter. It is located within the moderate grade. As you know, between 2 to 4 centimeter, it is mild. From 4 to 6, it is moderate degree. More than 6 centimeter, it is severe degree of prolapse. So we have here moderate degree of prolapse for the posterior compartment. Regarding this anterior bulge of the rectum, this is called anterior rectocele. It is filled with the ultrasound gel and gas locules. We need to measure this one. We can measure this one by drawing a line parallel to the anterior anal part, then line a perpendicular line from the anterior rectal bulge towards this line. This one is measuring 3.6 centimeter. We are applying a rule of 2 for rectocele from 0 to 2 mild degree. From 2 to 4, it is moderate degree of rectocele. Above 4 centimeter, it is severe degree of rectocele. So we have here moderate degree of anterior rectocele. We don't have any posterior rectoceles. Also, we should search for any interception, either mucosal interception or full thickness interception. We don't have any mucosal or full thickness interception, either intrarectal or intraanal. We don't have any type of interception. We need to add something here for a little bit, and it's one of the most important tips. Look for the uterus. The uterus is compressing. In the dynamic image, the uterine cervix is compressing the rectum and the rectal wall. Look here, the gel is markedly attenuated in this segment. So we have like functional obstruction added to the prolapse of the posterior compartment. This one is very important as well to comment in your report. So in conclusion, we have significant or moderate degree of rectal prolapse. Look for the H line here and M line 5.3 and H line measuring, it is measuring around 8 centimeter. We are applying also a rule of 2 between 8 and 10 centimeter it is moderate degree. So we have here in conclusion, we have moderate degree of posterior compartment prolapse and the mild degree of anterior and the middle compartments. And this one we can call it collectively descending perineal syndrome. Thank you so much.